We will get started shortly. And hospital association staff, if you can let me know when everyone is on and able to record, and we can go ahead and get started. Looks like we have a good turnout today. I was just commenting to our panelists that there's a lot of sick kids out there, and probably a lot of interest in this topic right now. WSHA staff, how are we doing with conferring recording privileges? Are we making progress there?
I believe I have most of mine on.
Okay, all right, super. Yeah, just keep me posted.
Too. Me too.
Okay, Kendra and Cindy, are you both set?
All set, thank you.
All set.
Okay, super. Thank you so much. And again, good morning, everyone. My name is Taya Briley. I'm the Executive Vice President for the Washington State Hospital Association. We appreciate you being with us this morning to talk about what is happening in our state on hospital capacity, and in particular, what is happening with room in our hospitals for kids, for our pediatric patients. We asked you here today because we think it's important for the community to be aware that hospital emergency departments across Washington are very strained right now. Many are exceeding 100% of their available capacity, and this is especially true for pediatric emergency departments. They are especially strained right now. Seasonal illnesses and the flu and COVID-19 are spreading in communities across our state right now, and people are in need of care. We are finding that often when patients are coming in, they are sicker than normal because many have experienced delayed care due to the COVID-19 pandemic. And every year at about this time, we are thinking about and preparing for what we call respiratory season, where hospitals are adding space and supplies and staff. And this is a really challenging year to be able to do that because already our system has been operating under a lot of strain, including particularly for staff. Like all other industries, the hospital and healthcare space is experiencing staffing shortages, which makes responding to a surge of this type especially challenging. Nationally and here in Washington State, respiratory syncytial virus, or RSV, is circulating widely right now. This is a virus that can be especially dangerous for young children, and it's impacting kids earlier in the season this year. And this is putting increased strain on children's hospitals and pediatric units. And we think it's important for the community and especially parents to be informed about what's happening so they can take steps to keep kids healthy and know what to do if their kids get sick. I am really happy to have experts with us today who can shed some light and provide some additional perspective for all of you and for our communities. I'm going to go ahead and introduce them right now, and then we'll, in just a moment, turn to them to have them provide their perspective. So first we have Dr. Tony Woodward, who is the Medical Director of Emergency Medicine at Seattle Children's Hospital. And next we have Ben Whitworth, who is the Chief Operating Officer for Marybridge Children's Hospital and Health Network, located in Tacoma. And we have Dr. Mike Barsotti, who is the Chief Administrative Officer for Providence Sacred Heart Children's Hospital in Spokane. And a little bit later in the program here, we'll have Dr. Mary Alice King, who is the medical director of Harborview's Pediatric ICU, and she's an associate professor of pediatrics at UW Medicine. And she will be talking today about the work of the Washington Medical Coordination Center, which some of you may remember from prior briefings, is a group that level loads patients across the state to make sure that we have room to care for everyone who really needs that higher level of care. And so the WMCC is increasingly turning its attention to pediatrics and making sure that we have enough pediatric beds available. So in a moment, we'll hear a little bit more from these panelists, but first I want to give you a bit more information about what is happening here. So the current RSV surge is putting extreme pressure on an already stressed system, and that is leading to backups in care and longer wait times for urgent and emergency care across the state. Some contributing factors include an increased demand for pediatric emergency services and the complexity of illness due to delayed routine care. And we also are having an increase in children who need behavioral health services and have been unable to access those services in the community. And so they are presenting in emergency departments and putting pressure on the need for those emergency departments to be able to respond to the acute situations that are presenting there. And another reason is that pediatric patients are increased. We are experiencing an increase in long length of stay pediatric patients. We've talked about this some in the context of adult patients, but this is also dynamic with pediatric patients. For some of these kids, social services cannot be met in the community, and so they may come into the hospital for a healthcare need and they can't be discharged because their social service needs can't be met in the community. And so they wind up essentially being stuck in the hospital for weeks and sometimes months. And we can't find a placement for them in the community. So they are unfortunately needing to be cared for in the hospital, which is not a healthy place for them to stay. And it's not a good use of a hospital bed for those kids either. RSV and influenza continue to spread across the country, and would just mention that Washington hospital leaders and our regulators and state agency officials are really working together to manage this here in Washington State. And I want to just take a moment to particularly thank our own Washington State Department of Health. They have been tremendous in their partnership over the last couple of weeks, helping hospitals through the regulatory process that will allow them to increase their number of beds and create new spaces and rooms for pediatric patients, including in pediatric intensive care units. And also we will, as I said, hear in a little while from Dr. Mary Alice King, who will be talking about the level loading that is taking place through the Washington Medical Coordination Center to make sure that no one in the state goes without care who really needs it. And I do want to mention this is a process that is unique to Washington State. Not every other state has this. And we are really fortunate to be able to lean on this system to make sure that our patients have the care that they need. I'm now going to go ahead and turn it over to our panelists, and we will first hear from Dr. Woodward. So Dr. Woodward, would appreciate some remarks from you.
Well, thank you. Can you hear me okay?
We can, thanks.
Thanks. Well, it's a pleasure to be here, but I'm sorry that we have to be here. We are in crisis mode, as you know, and bordering, if not already in disaster mode in our emergency departments across the state. We traditionally like to say that the ERs are the canary in the coal mine for the hospital systems. And right now our ERs are failing because we are at such high capacity. All the things Taya mentioned are true. Our ER is at 100% capacity, almost 24 hours a day, and in the evenings up to 300% capacity. And what that means is that patients who come for emergencies are treated immediately, but for people who don't have an emergent issue, there's a longer wait. And we're seeing our service levels drop. Our left without being seen is increasing because people are unwilling to wait for a long time. And it's really an amalgamation of a lot of issues. It's huge volumes, huge surges, the viruses, the triple-demic, as we've talked about, it's really a twin-demic at the moment with the flu and RSV, and really a lack of availability in the hospitals, which are full, and a lack of availability in the communities, which are full, compounded by the staffing crises in all those places, has really led to a spot where the ED is the last resort for many of these patients. One of the things we've tried to get across to our patient population is if you have an emergency, come to the emergency department. We triage by acuity, not necessarily by the time you came. And although someone may seem sick at home, once the medical eyes are on them, we may recognize that they're not deathly ill and spend some time allowing them to sit in our environment, while the ones who are much more significantly ill or need immediate intervention, we're able to manage right away. I think there's a lot of things we can do to combat this. I think that's at Children's, and I'm sure at my colleagues' hospitals as well, we've really gone above and beyond to try to identify every possible nook and cranny to store patients or treat patients in our inpatient units. We've increased our medical and nursing staffing in our emergency department as much as we possibly can. We now see patients in hallways, in and outside the ED, in a storeroom, in several lobbies, and in a tent to try to make up for this volume. We need to expand even further because we're not meeting the need currently. I think this is going to go on for a while. We know that RSV came a couple of weeks ago, and RSV is a disease we see every year. It came a little earlier than expected on top of some COVID, which was dropping a little bit. And now in the last week or so, flu has raised its head. So we're going to have an awful lot of very sick children, many who just need symptomatic therapy, but many who are sick. And we would recommend to our patients that you try to work with your primary care provider, either in person or with telemedicine, recognizing that they're definitely overwhelmed as well, and they don't have maybe the capacity to expand as the ERs do. Try to get into alternative levels of care if you don't have a true emergency, but don't ever hesitate to come to the emergency room if you have an emergency. And if you're sick, try to stay away from other sick kids. You know, we stopped masking, so we know that in school, as soon as kids go back to school, just like when they used to go to daycare before COVID, everybody got sick. Well, now everybody's getting sick, and it's not only the kids in school, it's the people at home. And just a reminder to families that the viruses don't only live in our secretions and our cough and things like that. They also live on the hard surfaces of our doorknobs and our toys and our binkies and things like that. So trying to have families not share those things and recognize that there's a lot of opportunities at home to perhaps prevent the spread within a household as well as prevent the spread elsewhere. So I think I'll stop there. I'm happy to answer questions as the panel goes on.
Thank you so much. Really important reminders and useful perspective to have from Seattle Children's. I'm going to go ahead and turn it over now to Ben Whitworth with Mary Bridge.
Yes, I am Ben Whitworth. I serve as the Chief Operating Officer here at Mary Bridge Children's Hospital and Health Network. I want to share what we're doing from an operations standpoint to address this challenging situation. It's highlighted by Dr. Woodward. Like children's hospitals in this region and all over the country, Mary Bridge is experiencing an unprecedented surge in patient volumes. Most of our physicians and team members that are here have all reported they've never seen it like this, and all the numbers are indicating like that as well. In the past several weeks, our emergency department has been well over 100% capacity every day. Our current capacity wait time, just as an example from today, we currently in the morning have 23 patients in the waiting room. We have children in our waiting room that have been waiting since 10 o'clock last night, so greater than 12 hours. For patients that need to be admitted from the emergency department to the hospital, hold times have been averaging over 24 hours for that. And so at any given time, we could have 6 to 8 patients holding in the emergency department, waiting on a bed on the inpatient floors. Right now, currently, we have, as you mentioned, it's not just respiratory. We have behavioral health crisis as well in this region. There are 5 patients in the emergency department waiting on a placement for an inpatient bed. The average hold time is in days. For many of those patients, these patients require one-to-one staffing and additional safety precautions in place. We have one patient, one behavioral health child who's been in the emergency department holding for 347 days as of today. All of this adds to the stress of this current respiratory surge. Our recent data and some of our testing results, over 60% of our emergency department visits that we're seeing are respiratory related, and about 80% of our hospital admissions right now are respiratory related. These numbers will change daily. Dr. Wilbur mentioned flu, it's coming back too, but about of our virus tests, 51% are positive for RSV, 27 rhinovirus, and 13% for flu. So that number is rising here as well. We at Mary Bridge, we are seeing our highest ever admissions for RSV in our system's history. From handling this from an operations perspective, we did stand up incident command 3 weeks ago, which is an interdepartmental task force to help address multiple impacts of the surge across our hospitals and our networks and clinics. And we knew that we would need that to plan ahead. We already have a strain on the healthcare system, staffing shortages, financial challenges, the children that have behavioral health needs that we've discussed. And so as we've been looking through that, I just want to recognize our team that's been incredible, lending a hand wherever they can. We've had leaders that have been rounding in our emergency department waiting rooms, just helping provide and have extra cleaning resources on hand with our staffing challenges. Some of the things that we've done in the past 3 weeks have been to advance our triage process and have extra nurses in our ED waiting rooms and rounding with these patients before they're called back into the department. Our inpatient hospitalist physician team has been working extra to treat patients in the emergency department as they hold and wait for a bed upstairs in the hospital, so that the emergency department physicians can then provide emergency care to those patients who aren't holding. We're assessing other elective units in the hospital, like a sedation unit, how we can use that space for more bed capacity, as well as additional staffing capacity as well. Our adult hospitals and the multi-care health system have been supportive and are partnering to help keep patients that are older and meet certain criteria. For example, like a 16-year-old above a certain weight that present to their emergency departments. They've been holding those patients there and keeping those patients as opposed to transferring them to Mary Bridge, just to allow us to treat the sickest and the youngest here with those pediatric specialists. And of course, we've been partnering, I know we'll hear later on, but with the Washington Medical Coordination Center and Northwest Healthcare Response Network as well to address the regional surge. Staffing was a challenge before this most recent impact. And so we're continuing to do things such as offer incentive pay for nurses and staff who take shifts. We've said nurses a lot. Respiratory therapists is an extreme challenge. I know for all of our hospitals and pediatric respiratory therapists is yet another specialization where we have a shortage. And one other thing that we're working to do is have additional providers that may not work in the emergency department normally. So physician's assistant and nurse practitioners and even primary care pediatricians, getting them the right privileges and credentials to help see some lower acuity patients in our ED as well. From the community's perspective, we recognize what people are hearing and seeing on social media, and of course it could be scary and confusing for parents. And so Dr. Wilbur, we're here for the kids. Come to the emergency department if it's an emergency, but don't make the ED or urgent care your first stop unless it's truly an emergency, because the urgent cares are overwhelmed as well. In terms of being our level 2 pediatric trauma center here at Mary Bridge, we're a regional transfer center and care for the sickest kids in the community. And so we want to make sure that we reserve those resources for those sick kids. One of the statistics that our primary care team has been helping share on our social media has been that this is from the American Academy of Pediatrics, almost all kids will get RSV at least once before they turn 2, and a very low percentage of that need hospital care. So monitor symptoms, check with your primary care physician to make sure you have the right level of care. You also, Dr. Wilbur also mentioned the practices for good hygiene that we've gotten used to through the pandemic, but we don't have masks anymore in schools. So the washing hands, covering coughs and sneezes, staying home when you're sick, I cannot re-emphasize that enough. And then for established patients, at least within our system, we're recommending utilizing the patient portal functions and MyChart to contact the pediatrician's office to get help as well. Mary Bridge's mission is to partner and heal for a healthy future for children. So thank you for having me on today. to help partner with us and our colleagues here to spread the word about what's going on in our hospitals. Thank you.
Thank you so much for providing that perspective. And yes, masks are no longer required in school, but it is certainly an option to wear a mask. And so that may be one thing that folks want to be encouraging their family members to do when they're in indoor spaces. So with that, I am going to go ahead and turn this over to Dr. Barsotti. I think, am I getting closer? Barsotti.
Perfect.
Okay,
Barsotti.
okay. Practicing pronouncing names. So he's the Chief Administrative Officer for Providence Sacred Heart Children's Hospital in Spokane. Thank you for being with us.
My pleasure. Thank you. Good morning. Well, this is the beauty of going third, right? So I want to start by echoing or thanking, Dr. Woodward and Mr. Whitworth, because a lot of what needs to be spoken about has already been mentioned, right? Our ERs are under stress. Preventative measures are important. Things like good hand washing. If your child or you are sick, don't go to school or work. I know masking is an issue, but truly masking prevented disease in the last 2 years from occurring. So it's something to think about, right? But really, and then remember that influenza is beginning to increase as well. And there is immunization vaccines that are very effective against influenza type A this year, I think is the predominant. So that's really important. I think the other thing that the two did a really nice job of, and I just want to sort of get on there, echo what they said, is to thank our staff for the amount of work that they're doing to make this surge doable. Our nursing staff, our RT staff, our respiratory therapist staff, but house cleaning. There is so much that goes into how we manage patients and what's going on. And so a shout out to them. I think every hospital system is trying to find the right mix between staffing, dollars, keeping people healthy, keeping people sane. And so we're all working on that. So I just wanted to echo those sort of things that are important to every hospital system, despite where you are. At Sacred Heart specifically, so on the east side of the state, good news, bad news. I feel like we're probably a step behind the west side of the state. So we are definitely in surge, but we are just building to the level that they're being described on the west side, which means it's coming. It's not that we're going to get away from it. Specifically for us, we are also over capacity at this point. Our ER is taking the brunt of what's going on. We are looking at ways to see more patients more efficiently and get of course, the acute kids, the sicker kids seen first. We have our physicians on a callback system where if there's a peak and there's an increased number in the ER that can't be managed by the staff that's there, physicians are coming in on off shifts to help cover and see patients. We have nursing staff that are coming back and helping out, so thank them for that. We have respiratory therapists running circles around the hospital trying to manage all this. All that being said is that we're over capacity in our emergency room, but doing everything possible to take care of the children that come to us. And so to echo everyone else's statement, if your child is sick and truly sick, please come to the ER. Do not avoid the ER. But if your child is beginning to get sick, please contact your primary care provider. The other little piece of caveat I'm going to share before I go back to Sacred Heart is I happen to also be the president of the Washington chapter of the American Academy of Pediatrics. So what we're hearing from our colleagues statewide is that the pediatric offices are very busy as well. So this is hitting every level of medicine. So I kind of wanted to share that and for people to understand that. Our hospital is running, and this is going to sound like we're doing better than everyone else. We're running about 110 to 120% of capacity, which sounds better than Mary Bridge and Seattle Children's, which is a sad statement. We do have the benefit of being a hospital within a hospital. So we have been able to pull a reserve area from the adult hospital to expand our care. So we have extra beds now in pediatrics. We are lucky at this point that our nursing staffing is okay to manage all the patients we have, as well as the reserve beds that we're using. But we're keeping an eye on that daily. The staff is doing a phenomenal job. Probably for us, when we look at our census, there's other kids in the hospital that are not respiratory as well. We are approximately 50% of all admissions to the pediatric hospital are respiratory, and almost all those right now are RSV. And about 50% of our PEDS ICU is filled with RSV right now. PEDS ICU capacity statewide remains problematic everywhere, and I think Dr. King is going to talk about that in a minute. But really trying to manage the sickest of the sick kids and sort of balancing that with how we can use other resources is sort of where we're working, which brings me to our partners. So we're working with the Tri-Cities, Cadillac, Moses Lake, Good Sam's, and even in Kootenai to use their pediatric resources to back transport children that have gone through our PEDS ICU, but try to reserve capacity at the children's hospital for the sickest of the sick, trying to set up telehealth with those hospitals to maybe allow them to take care of a little bit sicker child with our expertise at the same time. So we're working with our partners in the area. And then finally, I wanted to touch a bit on prevention. I think prevention is important. Immunizations, get your flu shot, keep your kids up to date with your immunizations. COVID is not, in all fairness, not hugely contributing to the surge right now. That may change as the surge continues on. And so it's important that we do our part in trying to prevent stuff, and then all the other stuff that was already mentioned in terms of good hand washing, minimizing exposures to that end. I'm going to stop there because I think everything's been mentioned by everyone else already. Thank you.
Thank you very much. Really appreciate that perspective. And one thing that's interesting to note is, you know, when we had the first COVID surges, we had a lot of pediatric capacity that was available. And so those younger adult patients were sometimes being cared for in pediatric beds. And now we sort of have the reverse that is happening, where we've got our older kids that we are caring for in maybe adult beds. So it's a testament to the way that the system is really working all across the state to try and make sure that no one goes without care. And I am really pleased that joining us today is Dr. Mary Alice King, who is the medical director of Harborview's Pediatric ICU and associate professor of pediatrics at the University of Washington at Medicine. And she is doing work with the Washington Medical Coordination Center. The WMCC has been, as I mentioned earlier, integral throughout the last couple of years to making sure that no patient who really needs care is going to go without it, and is now really turning its attention to this pediatric need. So Dr. King, I'll turn it over to you.
Thank you so much for that introduction. And actually that transition is perfect. I think the one thing that my pediatric colleagues are living day in, day out right now is thinking about this as this is our COVID. This is our moment in pediatrics. And we sometimes work a bit in a silo, so it can be hard at non-pediatric centers to feel that. But right now, that is the stress in our pediatric hospitals. We're terrified that we won't be able to take care of all the kids. We only have about 500 pediatric beds in Washington state. And of those, only 122 are pediatric ICU beds. So that is a very small percentage of our pediatric population, which is approximately 1.5 million children. And so this is why we're here today. This is why we're reaching out. This is why you're hearing the tone of voice in my colleagues' voices, because we are scared. And you're right, back in COVID time, pediatrics did help out our adult colleagues. We were able to admit some of those younger adults to pediatric ICUs. And I remember because I took care of them. And that is one creative solution we're looking towards. Can we admit older teens to adult units? But I got to say, there's a lot of creativity going on right now, and whether it's in general pediatrics, in the ER, on the floors, in the ICUs, and it's creativity in pediatric hospitals as well as in small rural community hospitals. Those are some of the folks I feel for the most. So yes, so I'm here today because I have been, as medical director of the pediatric ICU at Harborview, I have been very close to my adult colleagues who have been working on the WMCC during COVID from an adult perspective. And this is an opportunity to partner with them and use some of the infrastructure they've already built for statewide balancing act to try and get kids in the right places so we can take care of all the children. And so right now we are actively stepping in to provide those pediatric resources and infrastructure into the WMCC so that sometime in the very near future, if you are taking care of a sick child and cannot find a bed space, you can give the WMCC a call if you've gotten already nowhere to go. I'm gonna, as in terms of the WMCC, I assume that most folks on this call know what that is. It's a Washington Medical Coordination Center, and it's a small infrastructure of experienced nurses and docs who are really our lifeline to call in the state of Washington if someone has not been able to take care of a very sick patient. So up till this point, that hasn't been a resource for children, and we're trying to create that right now. The Harborview PICU faculty typically take care of kids with trauma. So you can imagine in the winter season, we have thankfully a few less of our traumatic injuries. So we have a little bit more bandwidth. So we're trying to be creative with the resources that we have. And so the pediatric ICU faculty at Harborview will be able to step into that role of providing pediatric expertise to the WMCC. I guess I want to stop there and see if you have any questions for me. I echo everything that's already been said. I can't overemphasize the needs to consider masking if you have a child less than 3 in your family, hand washing. Please vaccinate for influenza because that is already coming and is only going to make this worse. So anything we can do to increase pediatric flu shots would be great. And just thank you to all of my colleagues because this is a team effort. Thank you.
Thank you so much, Dr. King. And I think Dr. King and our other panelists have really emphasized a lot of the preventive steps that can be taken in terms of vaccinations, both for flu and for COVID, masking when you're in those indoor spaces in particular, making sure that you're doing your hand washing and attending to surfaces, especially have a sick person in your house. And also appropriate use of the emergency department. Our emergency departments are really overwhelmed right now. If you have an emergent need, absolutely use them. But if your need is not emergent, please consider urgent care. And your first stop is your primary care physician's office. So just really being patient if you do wind up in the emergency department, understanding that emergency departments will take care of the sickest folks first. And so while you may have been one of the first to the door, you may not immediately be seen depending on what others' needs are who are there. With that, I'm going to go ahead and open it up for questions, and our panelists will be able to have some dialogue with all of you. Thank you for being here for this. I should also mention it is fine to go ahead and chat in questions as well. Oh, I see Kate Walters has her hand up. Go ahead, Kate.
Yeah, thank you all so much for this update. It sounds like you are in a pretty tough situation right now. As we head towards another potential COVID surge, and obviously as the flu season kicks off, it sounds like RSV has been the early end of this season. How confident are you that our current system can withstand the potential surge that you're about to see? And then also just a secondary question, as we head into the holiday weekend with Thanksgiving coming up, what are the main things that you want families keeping in mind as they're looking towards gathering with others?
Thanks, Kate. I will just mention before I open it up to the panelists that Washington State is one of the states in the country with the fewest acute care beds overall. And so acute care beds are a precious resource here. However, we are also one of the most collaborative states in the country and have some of the now best infrastructure for managing this type of acute bed crisis that we are in. And so I'm feeling really good about the willingness of folks to work together to level load patients. It really is a stress on our system, however. And so this is an important opportunity for the community to be aware of what they can do to help with this challenge before us. So I will open it to the panelists to further comment and also say what they would like for folks to be thinking about as we head into the holidays.
I can jump in. I think you're right to be worried about the holidays. I think we're going to have to make some tough decisions. If people are sick, they should probably not join in the holiday celebrations, even though that's going to be difficult. We're very scared. I think Mary really said it well. We're very scared. Our ED now has more patients in it now in our 35-bed ED than we have people on this phone call. So we're at 200% capacity at this time of the day, which is almost unheard of. In the past 2 weeks, we have averaged more than our highest volume ever before this surge. So to put that into some kind of context, we are really pushing hard. The other piece about the holidays is that our staffing gets lighter on the holidays. We sometimes don't have as much depth in our staffing. So unfortunately, with these illnesses, these are not convenience illnesses. These are illnesses that people really need to be seen for. And when we have less staffing to manage our inpatients and less staffing to manage our outpatients, it just will lead to a slower service for patients who need to be seen. I think that's really, really hard. I think maybe the bright light in this whole process is that our state, Mary and others have really, we've been through this before. We've thought about Ebola, we've thought about COVID, we've thought about all the issues, how we come together as a team. And as I watch in our hospital with our EOC, our Emergency Operations Center, that's been up for a while, it's amazing how every day there are opportunities to get better and everybody is all in. And I think I see that across the state as well. This is not an isolated issue. It used to be, those patients in the emergency department. Now it's our patients in the emergency department. We know that there are patients who are going to be admitted, but they're going to prevent other patients from getting the care they need. So I really have seen just an amazing amount of cooperation and collegiality, but there's a limit. There's a hard stop to what we can do. And our hospital has the most patients it has ever had in the hospital currently. And we're sort of at our peak of RSV, but it's going to last for months. We're not at our peak for flu by any means, and that's coming soon. And if COVID raises back again, as somebody mentioned, I don't quite know how we're going to handle it.
Thank you, Dr. Woodward. I'm going to keep us moving. We've got a number of questions coming in. We have a question here about how symptoms of RSV and flu differ. I wonder, Dr. Barsotti, if you could maybe take that one.
Yeah, they can both have a respiratory component, as well as we did see on the East Coast, because they went through their surge before we did, that there was a subset of patients that came into the hospital with both influenza and RSV. And so we have to be ready for that. The flu symptoms are the fever, the achiness, may have a respiratory component, may not, where RSV is pretty much a respiratory disease process. So you'll see low-grade fever with RSV, some more breathing issues, increased secretion, those sort of things.
Thank you. And maybe Dr. King, you could speak to how do parents know when it's time to take their child to the doctor for whether it's RSV or the flu or whatever version of respiratory challenges they're having.
And I do want to echo, we are seeing co-viral infections, and it actually started with rhinovirus, enterovirus, and now RSV, and we expect influenza. It's already here, but based on what we see on the East Coast, it's coming in droves. So seeing co-infections just makes it more severe. But to get to your question, what should a parent be looking for? It's really increased work of breathing, respiratory distress. Sometimes you can see muscles move in the rib cage, nasal flaring, just breathing hard and fast. Sometimes it can be a persistent nighttime cough that's getting worse and worse. And then a real telltale sign in the little ones are just not eating, drinking, feeding as well, and less energy. So those are the big things. We expect kids to get fevers. That's normal. It's your body's response to trying to kick the infection. But it's those other things that you really want to look for and see a medical provider for. I do want to just echo, I think right now we need a major PR campaign because I don't think folks get this. I think people are so tired from COVID and they don't understand the urgency of what we're talking about. We need to flatten this RSV curve, and we need to think proactively about flattening the influenza curve because we are out of beds and parents are coming in just so confused why they can't be seen or why we don't have a bed for their child. And I'm actually terrified about what this can look like a month from now. So that's why we're here today.
Yeah, thank you for underscoring that. And I think are hopefully sharing the level of urgency here with folks that this is a very serious situation we're facing on behalf of our kids. To the point that you raised about anticipating and getting ahead of the flu surge, which seems to just be getting itself launched here. For folks who have maybe already had some illness, maybe they've already had a fever, maybe they've already had flu. Is it still worth getting a flu shot? Is it still worth taking those steps? And
100% yes. And I would go the extra step to say it's actually extremely hard to get flu shots for kids right now. Parents are working, they're busy, they're tired. We need aggressive, wide-scale flu shot campaigns for kids. Right now, for instance, the schools have shot clinics for COVID shots. Hardly any of them have flu shots. And it's just logistically super challenging for working parents. And those are the families that have small kids that are more vulnerable for RSV. So those are the ones oftentimes I'm worried about.
Thank you for that. Appreciate the perspective. We have a question here about our hospitals still requiring masking or going back to requiring masking. I will go ahead and answer that one. I will share that there has been and continues to be a requirement for masking in healthcare settings in Washington state. So that never stopped and it will continue. There is a current order in place from the Secretary of Health. So that continues. There is another question here about, are there plans to increase recruitment of travel nurses and plans to increase emergency funding for hospitals that are in dire need of staffing? We have talked on earlier media briefings about the really serious financial challenges that Washington's hospitals are facing right now. And while hospitals are doing all that they can to staff, I will just share that the travel staffing is a challenge right now. Hospitals are doing all that they can to incentivize extra shifts, to staff up all they can, including with travel nurses in many cases. But in some cases, the costs are becoming prohibitive to be able to keep those travel nurses in place. And so while hospitals are doing all that they can to meet this challenge, the costs of travel nurses are significant. And on top of that, many hospitals have also just provided really substantial and well-deserved pay increases to staff nurses. So would just mention it's a complex dynamic out there, and staffing overall remains very, very tight in our hospitals, like many other industries experiencing staffing challenges right now. So panelists, anything more to add on that front?
Just a comment. This is Ben Whitworth. As I've connected with colleagues across the Children's Hospital Association around the country, just even the availability of some of these travel nurses for pediatric specialists is not always there. We've struggled as we've looked for pediatric ER nurses, respiratory therapists, that the market for the travel staff isn't even there sometimes because of the intense demand around the country. This surge began to hit other parts of the country a few weeks ahead of time, which could have contributed to that, but it's a challenge even to find travel staff.
Thank you for that perspective.
I just want to echo that from our side. I think every system is going to make that decision based on their specific needs. But I think everyone is really committed to do what they have to do. And if that means travel nurses that take care of patients because that's our only option, people are going to go that route. But to Ben's point, it's not as simple as just saying, yes, we're going to do travel nurses. Remember that the whole country is going through this. So that resource is being tapped as well. But we're just doing the best we can.
Yes, I thank you for that add. There's a question here about, whether this is also affecting other states, in particular Oregon, for our border hospitals down there in the Vancouver, Portland area. Yes, this is absolutely a national challenge. I think one of the dynamics that is true in Washington state is that we do have one of the lowest number of beds in the country for our patients. And so that is definitely an added complexity here and requires a lot of reliance on one another to try and make sure that we are caring for all those who need it. Let's see, I'm having a look here for other questions. A question here about kids versus adults. Sounds like respiratory season may be hitting kids harder than adults. And do we expect that trend to continue? And how will it likely compare to the experience of adults this respiratory season?
So I can lean into that from the Asper town hall that I led last week. We're seeing trends that are 2 to 3 weeks behind our East Coast colleagues, and their severity continues to go up for children, and they are sending children to adult hospitals. Part of the challenge here is that on a regular day, only 6% of our ICU resources are for children, but yet 25% of our population is. And it really seems that kids not getting these viruses over those first 0, 1, 2 years for the past few years has changed their susceptibility. So they're just getting it more, and there's more of them getting it faster, spreading it to each other because there's more vulnerability, less herd immunity. And so we expect this trend to continue based on what we're seeing from our partners in the East Coast.
Thank you. Appreciate that. I think we may have gotten to all of our questions. Are there other questions for our panelists? Or to our panelists, as you've been listening to the conversation, is there anything that you are eager to add here?
Hello, this is Daniel from WSHA. I'd love to ask a question.
Go ahead.
Yeah, and sorry, my camera's off. I'm a little disheveled. I got my booster yesterday for COVID, and I actually had a mild reaction, so I'll spare you guys my face right now. But my question is, I'm trying to do my part, getting my vaccines, encouraging those I know to get the vaccine, and I still see hesitancy from people saying, oh, I don't know, I don't know if it's real, and they're still not convinced even after all of this. And I'm wondering how y'all are dealing with that, because I'm assuming that's an issue nationwide still, that have vaccine hesitancy.
Question on vaccine hesitancy. Go ahead.
So maybe I'll take a stab at this. And I don't know that I have the right answer here, but absolutely vaccine hesitancy is an issue that's out there. At the Washington chapter of the AAP, we're really trying to combat that at the primary care level to really establishing good relationships between your primary care physician and your family, and respectfully answering questions, and making sure that people have the right information to make the best decision for their children possible. We've learned that really that is the best way to combat vaccine hesitancy, is to really listen and share the science behind what's going on. But it's true, and the vaccine hesitancy that came out of the COVID pandemic spread to other vaccines for children, right? It wasn't just isolated to COVID vaccines, but has spread to other vaccines. And so there's a concerted effort in the state of Washington with the primary care pediatricians, and I am sure with our family practice people and colleagues, as well as hospital-based medicine, to really work through this and try to get the vaccine rates up to, as Dr. King said, flatten the curve, to really start protecting our kids, our most vulnerable population. We don't want them in the hospital. Nobody wants that. So trying to protect against that. But it's real.
Thank you. And I did miss a question earlier back on the topic of flu vaccines and trying to get a hold of one, which I know I experienced as a parent, trying to find flu vaccines. As Dr. King noted, it seemed like there were lots of COVID vaccines and had to work harder to find a flu vaccine. And whether any of our panelists have perspective on what is sort of driving that dynamic, if it's a shortage, if it's logistics, and what folks might do to make sure that they're able to access them.
I can just speak. I'm, in all transparency, I'm a working mom of 3 kids, actually 2 physician family with 3 kids. And the logistics of trying to get the flu shots have been very challenging. And getting them at the same time as the COVID boosters, like every clinic wants to register you separately. It makes no sense for working parents because they don't have the slots with them together. They can only do it a few days apart, which makes no sense from a vaccine standpoint. And then, like personally, my clinic then, after I had the appointments, ran out and called to cancel the appointments after. So that's how logistically challenging it has been. And then, yes, for school clinics, most of it is still just COVID vaccine. I know there were some emergency waivers about who could provide vaccine. I don't know if that's a challenge with flu vaccinations, whether it's only certain people can administer them. I'm going to lean on my public health partners here, but we have not had really large scale flu vaccination campaigns that I've seen in the community. And for working parents with young kids, and that's who we're worried about, we need to make this accessible.
Thank you. I think that's really important messaging here, that flu vaccines need to be more widely and easily available to the population. So appreciate that. We have just a few minutes left, and I will ask our panelists, what advice would you give to parents who are seeing these long wait times, are wanting to keep pressure off the system if they can, but they've got sick kids who have respiratory symptoms at home, and that can be a scary experience for a parent, the kid that may be experiencing some challenges with respiratory symptoms. So what tips would you have for parents who are managing this at home?
Jump in. I think this is really hard. As Mary noted, many of the families have not had sick kids before. Before the last couple of years, everybody had sick kids. It was just part of the rite of passage. And now there's a lot of sick kids who are getting sicker, and we haven't had the experience in our households to judge the level of illness. I think, as we mentioned earlier, speaking with your primary care provider's office for advice, going to nurse lines if they're available, trying to get telemedicine appointments. It's so easy. It's easy to see if somebody is really sick on a telemedicine appointment. We can figure that out and then say, yes, you need to be in the hospital, or no, this is what you should expect, and here's how this is going to go on. RSV is an illness that doesn't go away right away. There's no medicine for it. So when you get sick, we know you get worse for the first 3 or 5 days, and then you're just sort of in a steady state of illness for the next several weeks. Letting people know that that's what to expect, I think, is helpful. In addition to, Mary gave an amazing overview of what to look for. The other piece I would add to that is if they see any blueness around their lips or blueness anywhere else on their body, that suggests that they're not breathing well enough to sustain things as they are. So they should go to a hospital. And then, as has been mentioned, never hesitate to come to an ED. We have medical eyes on you the moment you walk into the ED. And if you're an extremis, we're going to take care of you the moment you walk into the ED. We also can then give a little bit of a sense of you're really sick, you're kind of sick, you're not so sick. And we would really encourage people to stay for the entire part of those evaluations, but at least that's a screen. And I think all of our ERs have seen that some of our patients don't stay for the entire evaluation, which never used to happen. But at least you've had a medical eye on it. You can't rely on that for what's going to happen if the disease is progressive, but at least you have a sense of they didn't triage me as high as somebody else, so things might be a little bit better than I thought at home.
Thank you. Appreciate that information. And it's a really good point. You know, even if you're waiting in an emergency department, you do have medical eyes on you. And so it's a safer environment if you're experiencing concerning illness than being at home. Okay. I want to see if any of our friends in the media have additional questions for our panelists as we head into the last couple of minutes here. Okay. Thank you. From our panelists, any closing remarks or comments?
I'll make just one more quick comment. One of the things that we've recognized as well is partnering with other healthcare providers that are not pediatric experts. So whether it's urgent cares or outlying community hospitals, emergency departments, et cetera. And we've really tried to reach out and contact those partners in the healthcare community as well for giving us a call at the PDR before they just transfer a kid or recommend sending them over. Maybe we can help manage a quick consult over the phone to avoid unnecessary ER visits. I think it was Dr. King who had mentioned we're still seeing families arrive in complete shock that it's busy in the emergency department. So the idea of awareness and public relations and spreading this word, I think is really the most important thing at this time, because no one, it's impacting us so greatly. This is our COVID, right? Like this should be on front page of everybody's mind, every school family, every school resource, every public health resource that can relate to prevention should be at our disposal to allow those as much prevention as possible.
Thank you so much. I think that really sums it up. This is our COVID from pediatric provider perspective. So appreciate everyone attending today for your time and attention to this really important situation that's playing out on the ground here in Washington State. And we will keep you all posted. And thank you especially to our panelists who took time today during a really busy time for all of them. So long.
Hey, everybody.